Well, this has been extremely enlightening. Before we end this discussion, I'd like to get final thoughts from each of our panelists. Dr. Amato?
I agree. I think this panel discussion has been very enlightening and opening up the door of the treatment agents that exist in kidney cancer. The landscape's changed dramatically. And now it's upon us of how to use these in combination, sequentially, and understand the population of patients that we've discussed over the last several hours, untreated first line to second line, third line, to adjuvant, and even potentially a neoadjuvant setting. So there's still a lot of clinical research effort that needs to occur to help define those dilemmas that we face still. And those are good dilemmas to have because we didn't have these years ago because we didn't have the agents to create these questions.
Thank you, Bob. And now to Dr. Choueiri. Toni, any final thoughts?
So I think, renal cell cancer, kidney cancer treatment is one of the most dynamic field, and if not the most, in solid tumor oncology now. We may need another, session in a year or less. Almost everything is changing. The cytoreductive nephrectomy, concept, the adjuvant concept, the combination frontline concept. And, we have to, stay updated and be able to answer important questions. My hope is the one thing we haven't, covered is that there will be new target coming. Totally new target outside PD-1, PD-L1, CTLA-4, and the VEGF receptor and mTOR that have activities and provide more options for patients rather than just seeing which drug or which trial can prevent some incremental benefit. But thank you, and I think this was a great, very engaging panel.
Well put. And now, Dr. Joseph, Rich, any last thoughts from your perspective?
Yeah, thanks for having me. I really enjoyed it, and I think I'd like to echo what Dr. Choueiri said. This is an exciting time for kidney cancer. So many new treatments, and I agree with what he said as well. Is that yes, I think by either sequencing these drugs, combining these drugs, we will continue to incrementally move the needle. But we need to do more than that, and I think there are going to be new agents that are going to do that. There's so many identifications of many targets already out there that exist in relatively large proportion of patients. So I think that's one place. I think there's a lot going on with liquid biopsies that are also going to help us manage the patient on a day-to-day basis and improve the way that we use biomarkers in the clinic. So I agree, kidney cancer today, 2018, this might be a very different talk even in 2019, so it's very exciting.
And finally, El Grandpa, Dr. Stadler.
Well, Dan, unless there's something my daughters didn't tell me, I'm not yet a grandpa officially. But I would sort of point out that this has been a very exciting field for me personally. When I started here, there were sort of 10 of us in a room at ASCO discussing dosing of IL-2 and interferon, and now to talk about sequencing drugs, choices of VEGFR TKIs, different combination of IOs, neoadjuvant, adjuvant therapy. This is tremendously exciting, not only for us, but the opportunities that this gives for our patients, the ability to treat patients for a long time, the ability for patients to be alive many years longer, to enjoy their families, I think has been a tremendous joy, I think, to me. And the additional questions that have been raised and have been discussed here, I think only point out that much more is to come. And so this has been exciting, and I really appreciate the opportunity to share some of my thoughts here.
Well, thank you all for your contributions to this discussion. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.